left ear pulsatile tinnitus in about November of last year. Gotten to the point where it's now significantly impairing her quality of life.
In the left ear?
Left ear. Significantly impairing her quality of life. She's having trouble working, difficulty sleeping, and she had an MRI externally, which we don't have, suggestive of some vascular malformation on the left side. Underwent a diagnostic angiogram, I think, earlier this year, which you've got up at the moment, I believe, and then had a treatment on Monday just gone.
Okay. Okay, good. So we're going to, the first thing that showed there was something going, do you know what this is? What is this branch? What is this vessel?
That's a tentorial branch.
Okay, what tentorial? Now we're going to go a little more sophisticated. Tentorial means, is it medial tentorial? Is it basal tentorial? How do you distinguish those two?
Based off the AP, it looks like
The
medial
AP.
tentorial.
Okay, so we'll look at the AP. I'm going to put it for a moment here just to see it big. Okay.
No, that's actually
Good.
correct.
This is very good. Can you see?
Yeah, we used left and middle.
Okay, so where can you see that artery in this picture?
Yeah.
Okay, so it's this one, right?
Uh-huh.
So what do we call, this is right, it's medial tentorial. It's exactly where the tent is coming down, okay? If the same vessel coming from the C5 segment, but you see it in the AP, goes straight like this, it's called basal tentorial, okay?
Uh-huh.
Now, for the most part, what diseases would make this vessel become big?
Dural ABS.
Absolutely, what else?
AVMs.
Meningioma, AVMs can be dural, but you know, for a cerebral AVM to have this branch is unlikely unless it's got dural contribution, right? But meningiomas, correct. Okay, so things that happen in the meninges. Okay, but it immediately tells you that. Now, obviously, this other picture is also very interesting, right? So I'm going to put, this is the, and comes to our rules when we see a vessel reaching the midline, right? Here we become, okay, so let's see what, can you tell me what is the blood supply that is abnormal here? I mean, we know something's going on across the midline, right?
Yep.
Bingo, right?
Uh-huh.
So what artery, can you identify me the artery? What's this one?
That's the occipital artery.
That's the occipital. And what happened in this angiogram? What happened to the occipital?
Oh, it was only partially selected.
Correct. So that means your catheter is, there's something else that is very well opacified, right?
Uh-huh.
What is this one?
Ascending pharyngeal.
Ascending pharyngeal. Now let's get a little more sophisticated. This is
The anterior.
okay, this is the anterior
Yeah.
segment branch, but you can see here coming down, okay, it's ascending pharyngeal.
Yeah.
So it's the pharyngeal component of the ascending pharyngeal. An interesting thing is when you see this loop here, this is the uvula. Okay, so in this particular individual, the pharyngeal supply is dominant from the ascending pharyngeal. This same thing can come more frequently from the ascending palatine,
Huh.
from coming off, and we'll start looking at those things. But you can tell this is again the midline because it's the uvula is. Greg, stay with it. You're doing good. What is this one? Ascending pharyngeal. So we went through the anterior branch.
Yeah.
What is important of this anterior branch? Goes to the palate, but what would be the anastomosis to this territory? How else can we come to this territory?
Foramen rotundum.
Look warm, but from rotundum is all the way here.
Oh, Vidian maybe.
Medium, yes. This one is got an anastomosis. Usually it's a not well developed artery, but we can just see it from the distal internal maxillary. What about this branch here?
It's a neuromeningeal division.
Okay, what is this one here?
That.
And here would be what? Yes, don't be afraid, it is. the odontoid
Oh,
process. And this is it's gonna anastomose, it's occiput C1, C2, and it's gonna go to C3. It's a nice example. Okay? Could you tell me where the hypoglossal foramen would be?
So the neuromeningeal division.
This is the neuromeningeal branch, right?
So where it
So
straightens.
some around here.
Yeah.
Okay? So this is a nice demonstration. So here the catheter was pointing towards the ascending pharyngeal artery. So when you look at angio, many things help you, to determine, is an artifact from the way I injected? You should be cognitive of all those things, okay? And then you can see that there is a prominent meningeal contribution, which is probably this one here. And then this one, the patient wouldn't have not moved that much. We could have tried to figure out how it restore. Okay, but hopefully you have more selective injections. Okay, so, and we know the disease on the other side, right? Okay, so you did another injection. This is the occipital, right? And to your surprise, it's not as prominent in the supply. It is already. Okay, and this is, the only thing is that all this network, when I look at it, I know one thing. It is transbony. It's not meningeal. But it reconstitutes, this is a meningeal artery. But it is through all this, you see all this transbony? Okay. And it's draining to the sinus, right? On the opposite side. Okay, so the money is going to be on the other side, right? Okay, but correct. Now, when you're doing a dural malformation, which vertebral artery is the one you should inject for sure?
Ipsilateral to
The
the
ipsilateral. The ipsilateral. Many times you get an angiogram, everybody's happy because you reflux to the other side and happy, but it should do the ipsilateral. Collateral circulation will always be more strong or more dominant in an ipsilateral thing. You ligate the external carotid artery, yes, there will be cross and from here lip, but the anastomosis of the occipital to the vertebral on a ligated is much better. If you're looking where the ligations are, to the ipsilateral circulation, okay? Jesus, this message is crazy. So that's okay. Interesting. Now there's some interesting, very great case. Okay, so here we see some contribution from the posterior circulation, right? And we're going to try to figure out what is contributing, right? We see a very prominent temporal branch. We notice a dual addition. There's something else here, right? And something else there. So superior cerebellar is another artery that gives dural branches, contributes to the dura, the superior cerebellar artery. And this is what I presume. But let's see if we can see it better. Okay, but you see this one is diluted, right? This one. Okay, so we have to figure that out. We'll see it we'll use collateral circulation to try to answer that question. Okay, so you were looking for, wow, oh, nice. Why did I get all happy here?
Now you can see
What is this thing?
spinal artery,
What spinal artery?
the cervical,
Which one?
the cervical.
No, but is it anterior, posterior, lateral, or what?
Anterior.
Anterior. And how do you define that?
It should be running directly along the midline. So if you look
Should
at
be in the
abstracted
midline,
views,
and then you have this. Not too bad. You have the
collateral with the
Right. And then here you can see this is the posterior part of the canal, right? This is the ventral. So here it is. One interesting thing about is we can predict from this picture that there will be a fenestration on the opposite side of the anterior spinal artery. You see this thing? I need to find another square. So if you did the other side, we're probably going to see another artery coming and filling this triangle. Okay? Why? Because the spinal cord embryologically is open, and then it fuses. then it creates only one interspinal artery, but that's why so frequently you may have duplication of interspinal artery because in diffusion occurred. Okay, now this is quite prominent. We don't see anything from above. Oh, I see something here. This is the lateral, posterolateral. Okay, Greg, can you see the odontoid process here?
No, not well.
Does anybody see the odontoid process here? Was it this one? It was, you see the odontoid process? Remember we said this anastomosis here with the vert? Right? Right here. Here it is. And how do I differentiate a spinal cord artery from the odontoid? This one always projects posterior to the vertebral. This one will project anterior to the vertebral. See?
Okay, yeah.
You see it here? Whereas here we see now the upper part, which I was looking in the AP, but there's so much movement. Okay? But you see now you see clearly, right, the odontoid process. You see how it's exactly the same thing. Agree? Okay. Good. Look how nice the interspinal artery. So now we need to see if we can do. Okay, where were we? Yeah, this is the AP for that. There's too much motion here. We can't see it, but definitely there is. You see it here, right? Those two will anastomose, will connect. Think of the interspinal artery is a collector, okay? And of course there's segments, but then it will come and give supply to one side of the cord and to the other side of the cord, okay? So this is the analogy is the lenticulus striate, thalamo perforators, all the vessels that follow the basilarity, and this is the continuation of this artery. But you see, very nice. Tomoyoshi, you see the odontoid process here in this picture? See or no?
Yes.
Okay. So the next you went to see the opposite side. Okay. Now we saw the sinus on the right carotid injection. Okay. So here, in addition to looking for the fistula, we want to see if we can see. Okay. So the brain is draining through the dominant right side. Okay. So we need to reconstruct what happened, if this is thrombosed or developed. We'll get to that in a second. Okay, but there is an interesting contribution, right? You see this network, right? Huh. Interesting. Because this probably is part of middle meningeal, whereas this is C5, but it's coming down like that. So this is basal tentorial. Remember we talked about the medial tentorial? Okay. You know, of course, it's a little bit dilated, not because it's behind the lesion. And now this artery, we've seen it before. Looks familiar. Where did we see it before?
From the left vert. Oh, sorry, from the right vert.
I'm going to just put it for a moment here. You see it?
Yeah.
Okay. So we see this one, right? So we've seen this one before. And now we're going to try to put it together. Okay, so there is contribution to the lesion, but we know there's going to be something more juicy. Okay, so you did an oblique. Who did this, Angel?
That was me.
Why did you repeat this injection?
To focus firstly on the lateral and the fistula point itself, but on the A plane, more of a Townes projection to look at the transverse sinus drainage.
Okay. Did it help you? There's also dominant MCA. It didn't help me. That's okay. Okay. What we do, yes, know is that this sinus is not thrombosed, at least not from here down, and it's not draining to cortical veins, right?
Yes.
let's see what happened here. This,
Oh,
okay, what happened here?
terrible injection.
Terrible injection. What is the mistake? What is the why? What is wrong?
Contrast is too dilute and the injection time was too long.
Right. So don't be shy to use non-diluted contrast in high flow lesions. Sometimes quite helpful. Okay, so you repeated it, right?
Yes.
Okay, sorry. Okay. But we have a similar situation as in the other side, right?
Yeah.
See where your catheter is primarily, looking into the ascending pharyngeal, right? Oh, what is this one? There's a blood supply to the 11th cranial nerve. Okay, and it may anastomose with a vert. C4 we call it. Seldom is so prominent. Okay, but it's very typical, comes from the ascending pharyngeal here. Okay, now you see definitely what's this one?
Sorry, which one?
This one.
Oh, the MMA.
And how do you know that?
Because it's got the straight channel as it goes through foramen spinosum.
Which is right there, right?
Uh-huh.
Okay, you see this branch, how dominant it is. Now you see a network. What is this? Arteries or veins? What is this? What am I looking here?
It's can't really delineate it because my contrast injection's too long.
Okay, so we're going to do a third injection. And now you're more selective in the occipital. What's going on this way?
Yes, that sometimes you have to push the downward arrow to go to the next. If you click the downward arrow, it will go to the right.
The which arrow? This one?
Like the downward facing
This one?
Yeah,
Mhm.
that's it.
Oh, I just click on the image.
Click on the image and then click on the downward arrow.
Oh no, click on the image. The big image, come down, click, and then press down.
Oh,
No, maybe not.
I don't know. It's weird.
Oh,
Maybe.
that's okay. So this is very nice because it shows you what we were asking, right?
What's the-
Now, what you can do too in a case like this, look what happened. The patient, the mask that was obtained here was in one period of the respiration of this individual. So this is a very good mask, but it's not the contrast because he's moving already. It's moving, you see?
Mm.
So what you can do in the screen, in the machine, you make this the mask,
Mhm.
and then you will get a very good picture, okay? Because here this is useless, but you get this information, right?
Mhm.
So what would you say, Greg?
So there's extensive arterial feeders from the left occipital artery onto the left transverse sinus with fistulization from the transverse sinus antegrade down to the internal jugular vein on the left with no retrograde flow.
Right. And what are these veins here?
The occipital emissary veins.
And how did this one feel? It's empty,
Just transosseous.
transosseous, and that's when this thrombosis. This is what the pathway that will become, right?
Uh-huh.
Okay. So, anyways, what fascinating is that actually you see how this angiogenetic response is seen in the wall of the sinus.
Mhm.
Very nice, right? Now there is one thing we're still missing. Oh, maybe it's here. There's too much movement. I'm looking for this portion of the sinus. Okay, and here you have a distal, external, very nice. Okay. Okay, look at that. It's actually, we don't have this segment. We needed the brain. Let's see if the vert drains that part of the sinus.
There should be a left vert run right at the end.
There's a left bird?
Yeah.
Okay. Okay, so we don't see that this part of the transverse sinus, okay? We don't see, we see from sigmoid. Let's see, we see it at the last injection. Something peculiar. Okay, fantastic. What is this? What is this thing?
C2 segmental artery,
And what is it opacifying?
the occipital artery.
Correct. Okay. You see it perfectly, the anastomosis, right?
Hmm.
What is this one here?
The odontoid.
Eh? Ah, gotcha.
Oh no, sorry, it's
Remember what we
yeah,
said?
it's
If
posterior.
it projects
sorry.
posterior
Yeah,
to the
yeah,
verb.
sorry, okay. Yeah.
Okay. You'll see. Now you're going to look at every angiogram you do. You're going to be looking for this arteries. I hope. Okay. There's also an interesting pica here. But anyways, let's finish with a dural malformation. I need to find. I'm missing a piece. Oh.
There you can hit up or down.
Go down.
No, the arrow, you can go.
You mean this arrow?
Go click there first and then I think that's
Click
the
here
word.
first. Then here.
That works.
All right. You learn something every day. So this piece of the sinus is non-existent, or we can't find it, right? What would be the best way for you to find that sinus?
I think on the left RCA injection, where I've done that Towns projection, you can see the left transverse sinus filling retrograde across to the right.
This one?
I thought it filled that one in nice.
The left RCA run, I'm not sure. It'll be further back. You know how they did that additional projection?
Here's the end.
Oh no, it'll be further at the start. Keep coming, 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 keep coming. Bit further. That one there.
This one?
Yeah.
Ah, shit, it didn't work. Okay, so click this one.
There you go. So if you run that through,
Yeah.
you sort of see it faintly there.
It's like a shadow, huh? Like,
Yeah.
but it's not normal.
And then on the lateral projection, I think you do see it late. So the run should go late enough that you'll see the native cerebrovenous drainage there. So that's the left side filling and then contralateral flowing across.
It's this side. This is the right side. This one.
That's
is,
the right,
is this
yeah.
one.
But
The one going
Just
but
there.
it's abnormal.
yeah.
What would be if you want to study the sinus and you can't opacify it with X-ray contrast? What could you do? What would you look at? MRI. Right? We live in a world that we have. Okay, so let's go back. Okay, so
my question, Dr. Berenstein, based off this is, can you ascertain that left transverse sinus is patent throughout its length, or would you conclude from the images you've seen so far that the left transverse sinus at the fistula point is occluded?
or not? Yes, there's something wrong. There's something wrong with that sinus.
Yeah, but would you say can you tell me that the left transverse sinus is patent throughout?
I
Or
would look at the
say,
MR.
would you say based off this that...
I don't think it's patent. I don't think it's patent.
Alright, yeah, that's what I thought too.
But I would look at the MR. I think the MR should be, but you don't have an MR.
Yeah, that's right.
Non-contrast and contrast MR should help you.
Yeah.
Okay.
So
Now, the patient has hearing
yeah, she had
noise.
she
That's the
had
only
that.
symptom.
Yeah.
Okay. So let's say if you want to treat this thing, well, first should be. It doesn't have a true cortical venous drainage, but it does have thrombosis, right? In this particular case, I would be more willing to treat it because the sinus is gone. How would you treat this thing?
Well, initially I thought that the transverse sinus from the point of fistularization proximally is arterialized, therefore it is not functional, therefore you should theoretically be able to coil off the transverse sinus, that segment.
But you need to include this. You have to trap it. If you just close it like here,
Yeah,
you may miss part of it.
yeah. In which case you potentially convert it to a high grade because you get
You can
arterial
convert
outflow
it,
via
right.
larvae.
But I think actually when you would come in transvenous, you can explore that, and actually you probably will find a channel. So you'll go beyond and then you close it. When you're going to close the sinus, you should look at the venous drainage of the cerebellum to make sure that you don't block a vein that can give you the biggest danger is to have a hemorrhage, from the drain. So you see, this is the dominant vein.
Mm-hmm.
So you just have to trap it from here downwards that way.
Mm.
And you would probe it. You would come in like this, and you would poke around, and you probably will find this. If you find this, then boom, 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 you go there.
Mm.
You can guide yourself. You can put a catheter to guide yourself at the highest. Look at all the externals, which is the highest point. You may want to put catheter in the right side, because remember, the right side came. Maybe the right side is the highest point. Remember when we did the right external?
Mm-hmm.
Okay, let's say this one. You see, it shows you the higher part of the. See, here's the sinus.
Mm-hmm.
Again, collateral circulation help us to answer the question.
So we did her treatment case on Monday, which is the next study, and went transarterial with onyx, but then had a transvenous balloon up.
You don't have to do transarterial knowledge. You just go trap that thing. This thing will all disappear.
Yeah, I think we wanted to preserve the sinus because she's relatively young, and we thought if we could embolize safely and preserve the normal flow through the sinus, then
But it's not existent.
yeah,
I think it's a simple thing to do. But if you want to do that, the best way to do that, we don't have the technology in this goddamn country, is you would have a, Copernico, there's a balloon made by Balt called, I think, Copernico.
yeah.
So you would put it all the way from here, say 1 or 2, and then you can, then you start injecting this thing,
Yeah.
and you actually see how it,
If you look at the next
So what is
study,
this one?
yeah, that's
Oh, you treated it?
yes.
Oh, okay.
So that's what we did. We actually used a transform in the sinus because that's the biggest we had, but it actually worked quite nicely.
It's a better angiogram because the patient's asleep,
yeah.
although the windows are.
So we had a septimini in the left MMA posterior branch distally, and then we had a transform 7x10 in the transverse sinus. The transverse sinus we actually passed the wire all the way through on the left side.
You were able to go all the way.
Yeah, and then inflated the balloon across the fistula point, making sure we didn't occlude the balloon over larvae's entrance, so preserved larvae's flow when the balloon was up, and then embolized that posterior MMA division and reduced the flow, and I think we restored antegrade flow through the sinus after the case. Still had some feeders from the petrous branch in the occipital and the retroauricular on the left side, but significantly sort of improved, so she'll come back for a second stage embolization.
Look at this, how fantastic. So this is with the miniceptor, right?
Yeah.
Look how nice you see the exact way it enters.
So this is with the transform balloon up.
Which balloon did you use?
7x10 transform?
Which one?
Transform 7x10, which is the biggest thing we had, but it actually included.
Is it what, a Boston Scientific? What?
Who makes transforms?
I'll show you.
If you don't have, let's say you couldn't, it wouldn't close the, you try and it's too small. What else could you do?
Striker.
Okay, what?
Use a stent, right?
Can use multiple balloons. I don't know.
You only have this balloon. You try it. It's not big enough. You put another one.
Yeah, multiple balloons. Yeah.
Sure, there's not a.
Exactly.
But you have to be thinking that way so that you know that the guiding catheter you're going to put can take two.
So that's with the transform inflated, and then you can see labe is still patent.
Let me see the neck here. Yeah, yep. I wasn't actually worried about it. Okay, so
So our initial embolization through the septum mini, we can only take down one of the smaller branches before the tantalum sort of clumped a bit. So we had to take out the septum mini, then switch to a normal septa.
this is interesting. Look how it's you have a waist here, so there is this. You're in a great position because probably this is that piece of sinus that we saw.
Or an arachnoid granulation.
Huh? Yeah,
Or an arachnoid granulation.
Right. I have a feeling you're gonna have to take the sinus.
So that was the initial onyx, which was a little bit disappointing. Like I say, the tantalum sort of clumped, and then we couldn't push it anymore.
What
so,
did you use? Did you use the 18?
Yeah, onyx 18. So that's after the initial and removal. You can see that small distal branch from where we embolized there. So we went out with a septa 4x10, coiled off that branch, and then proceeded to do another embolization from that distal parietal division. Again with transvenous balloon protection of the sinus.
How long did it take the procedure?
About 6.5 hours.
So this is when you went to for that branch.
So that's with the septa all the way in that tiny branch. So put a coil, I think 1x2 nano to coil that branch off to prevent distal sort of onyx spread. And that was our septa position. Again, balloon reinflated to check the labe was still protected. And this is the onyx from the septa 4x10.
So this is a bigger. Yeah, I don't
Yeah.
know why the media
More.
here we use the bigger. Something is funny how the injection is being diluted. What happened here to the
This
balloon?
is with the regular.
I think we intermittently deflated the balloon just to check that everything was still. We saw a tiny bit of onyx maybe going into the sinus, so we wanted just to double check the sinus flow, and it was all fine.
Okay. This is nice. This you see how you're getting the part of the occipital. That's better than the angel.
And this is post. Balloon still inflated at that point. Yeah, that's easier.
Wrote it down.
Yeah.
So this is where you stabbed.
Yeah.
Let's see what I dumped it for a branch. So you're gonna come back, huh?
Yeah, she'll be a second stage. But if you look at that run as it plays through, I think you can actually start to
This-
see normal cerebral venous drainage antegrade through that sinus now, mainly on the AP projection.
Yeah, yeah, you're right.
So there is some restoration of normal sinus flow.
Well, I'm not sure this is the sinus, but it wasn't feeling before. Yeah, here it is.
So it was all retrograde
Yeah,
previously,
yeah.
but now it
You're
looks like
starting
it's
to
starting
drain the
come.
brain this way. Yeah. Here's the fistula, right? Draining there, and this is brain.
So reduced the flow enough, and maybe we pre-dilated that stenosis / arachnoid granulation to allow for a bit more drainage.
Finish the dural fistula. Don't worry about the granulation.
And then shut down so we can't see MMA.
Yeah, look at very
or-
nice. You got rid of the right contralateral supply. So there, yeah, this, I want to see this one. See, it is superior cerebellum. Okay, nice case. A lot of good points.
Is your tinnitus better?
Right?
What does it
She's
say?
only day 2 or day 3 post-op now, so she's still pretty early. And on the dyna spin, I don't think, if you look at, there's a non-con dyna at the end to look at the onyx cast distribution. Come all the way south, I think the tantalum separator was a little bit harder to see, but if you window that out to a bone level, do you mind if I window that for you? Yeah, all the way, and then to the maybe top left.
Yeah, why don't you play with it?
Yeah, just 2 seconds. I'll put it.
I hate the window.
Yeah.
Okay.
So that's the onyx cast. So coming north to south, that's MMA expected coming down to the transverse sinus. But what I didn't, and that's going around the transverse sinus nicely, what I didn't really appreciate at the time is you can see this coming to here, then there's that. So I don't know if that's gone through hypoglossal canal, crept down and gone. That's hard to know. See that? Anyway.
So why did you do the CAT scan after?
I think just to look at the onyx.
Did you
And to
already saw
look
the
for-
onyx?
Well, it's the stuff you can't see, I guess, on the angiographic imaging.
Yeah, but just writing the patient with how does this help you? Looks everything's fine.
Yeah.
Okay. Okay, guys.
Thank you.
You're welcome.
Nice.
Nice case.
Nice case.
Yeah.